All right, so my name is Aaron Mostel. I will be your instructor today. A little bit about me for those of you who don't know. I am a paramedic. I work with the city of Fredericksburg, so I appreciate all these guys coming to watch. So Cindy and I had a meeting, and we started talking about RSV season, and I know they've had some meetings that have been planned to go with some Methodist physicians that have fallen by the wayside. And so we thought, well, in the interim, waiting for those things to happen, we'd probably have some classes here to talk about what we're going to see, what's actually going on with this disease process, and maybe what we can do for it. Okay, so that's the idea behind today. Again, my name is Aaron. I do talk fast, but I'm super chill, so if you guys have questions, stories, things like that, please ask. We did arrange to have a lot of your equipment here, along with Danielle, who's here to help just talk about some of the stuff that you might see here in the hospital. And also get to play with the mannequins. So like EMS folks, if you guys want to innovate the kid, like we're going to mess with that too, if you want to. That'll be after we complete this presentation. You will notice we are recording this class, and I was told I have to pause every few minutes just so they can do their thing. So if I stop, I'm not having a stroke. I'm waiting for her to wait. Okay, so any questions before we get started?
Romney, we only have the room until 12:30, so let's keep the stories to
Okay, I was going to tell something.
All right, I'm glad we could start that off. So a little bit more, I do not like to read PowerPoints to everybody, so that's not my gig. I'm going to talk, and it will probably go maybe along with the PowerPoint, but just fair warning. So respiratory syncytial virus, that's how you say it, RSV. The name syncytial actually comes from when two cells form and create a larger cell. So that's where RSV actually comes from, right? Because this is what's happening in the body, and we're going to talk about that because it's important for the signs and symptoms that we'll see with kids. So RSV, incubation period, viral shedding, 2 to 8 days. Let's talk about what this stuff means, right? So I'm no artist, I'll warn you, but I want to talk about how this actually works in the body, what RSV actually does. So our airway, let's just, again, no artist, but right, we come in, we go down, and we've got our lungs. Go up here, so we've got nasal, we've got oral, okay? So your carriers, your folks with RSV, they cough, they sneeze, they wipe their face, they play with their little dinosaur toy, they put it down. How do we transmit this virus? So when we cough, we sneeze, we hack, we've got these droplets, and if COVID told us anything, as long as you're more than 6 feet away, you're safe. That's not true, right? We know these droplets hang out in the air. When they land on furniture, they're active for hours. When they're in the air, if I just happen to walk by and I breathe them in, they're there, right? The little kids in daycare, when they're playing with their little dinosaur toy and they're putting them in their mouth, and the next kid picks it up and puts it in his mouth. So these cells, this virus, enters in through our airways, or our mouth, and they attach to the epithelial cells in the back of our throat, or up in our nasal cavity, right? So this cell attaches. Now this, I was in the military for 6 years, and I like to make things easy. So here, I'm going to think this is the command post. And in the command post, this is where your incubation and your viral shedding start, right? This is General Patton with all his soldiers, and he's like, all right, guys, we're here, we've attached, I'm holding on to these epithelial cells, and now we need to do our job. So now, your little kid, your adult, they're starting to say, oh, my throat kind of hurts, my ears hurt, their nose is running, they're coughing, they're hacking, they don't want to drink, their eyes are all red, they're sick, right? And we think like, oh, they're probably not running a fever, but they act like they've got the cold, right? Common cold. Did you wave? All right, we haven't waved yet. All right, so this is the command post, right? We're setting up, we're incubating, we're getting ready to make this person really, really sick. And so General Patton here, the virus, the cells, they start to morph. So the epithelial cells that are just sitting there in the lining of our airway start to rub together. And now they start to form, right? So we've gone from little tiny cells by themselves to one bigger cell. And as this starts to happen, some of the cells that are around our epithelial cells will start to die. And so our body's natural reaction is to say, hey, I need to send some cells there to start to fight this infection, right? And so we send our protector, our warrior cells, to this site, and those actually speed up the process of those other cells dying. And so as all this stuff starts to happen, our cells, our little military guys up here, say, you know what? My job now is to attack the bronchioles. So their job is actually to get way down here into the very, very tiny spots of the airway. And so I want you to think of like these guys are paratroopers now, and so they're jumping down ship. They branch off into our alveoli, right? So now you've got all these cells sitting in here doing their thing. Okay? So now the virus is there and it's doing the same exact thing. It's starting to fuse these cells. Our body says, no way, I need to fight this infection. So it sends our warrior cells in and they start to fight it. And so what happens here? We get inflammation. Right? So our airways become inflamed. We start to produce mucus, which is going to turn into mucus plugs. And we also make our cell walls that are down here to allow for gas exchange more permeable. So now we also can see an increase in blood flow and liquid into the linings of the lungs. Right? So swelling, increased fluid, increased mucus, all these things come together to create problems for us. Right? And so we take our kid that started off with a common cold. Oh, my throat hurts, I don't feel so good. And now, you're 3 to 5 days later, everything has transitioned into the lower airways. And we're wheezing, we're grunting, we're seeing pursed lip breathing, right? And they're becoming hypoxic. Okay? So this mucus that we're making down here starts to form a plug. And now we're not getting good gas exchange. This is a breakdown of what we're seeing with these kids that are super, super sick. Okay? Poor drawing, better drawing up there. Okay? So this mucus plug, if we get to the point that it actually plugs our airway, it can work one of two ways. It doesn't let anything through, it stops it. In that case, we start to see atelectasis. And so what happens here is your little air sacs start to deflate. Right? And we're no longer getting good gas exchange. You're going to have hypoxemia. I'm putting oxygen into their lungs, but it's not getting to the bloodstream. Okay? Our other thing we might see is it works as a one-way valve. And so as I look at this, the air comes through, but it's not able to leave the little air sacs. We get air trapping. And so for any providers in here, folks that look at chest x-rays, I'm going to see two different things, right? So if I've got atelectasis, it's going to be super, super diffuse in that image, right? It's going to just be real white, kind of ugly, hard to see. Or if I have air trapping, I'm going to start to look for that blunted diaphragm at the bottom of my chest x-ray. Okay, so a couple things I might look at and think of as I start to see some of these problems develop. Questions on any of this stuff? This is a brief, like, hey, this is how it works in the body. Dumbed down so I can understand it. Okay? All right. So that's the viral process in a nutshell. Let's talk about what we're going to see with our kids. So our kids, right? Or even adults. I guess I should talk before I move into this. Who's at risk for this? Everyone, right? Everyone. Now, the ones we're going to see that are usually really, really sick are going to be less than 6 months, or older folks, or people with congenital problems. Okay? You can also see like a neuromuscular disorder in little kids where they can't clear their airway very well. I always think of like Jerry's kids, like muscular dystrophy. They don't have that good air movement, so they're at increased risk here too. Right? They can't take care of this themselves. We got to help them. All right. So, any waves yet? Okay. So, let's see. Now that we talked about who's at risk, I can give you some numbers. The CDC says that approximately 60,000 children die a year worldwide. That number in the United States, significantly less. When you get to third world countries where they don't do anything for this, obviously that's where that number is really padded. But I will tell you about 2% of children less than 6 months will be hospitalized for RSV. So every 2 kids out of every 100, like, get it bad enough that they get hospitalized and we gotta actually do treatment for them. All right, so signs and symptoms, right? So we start off with my throat's sore, maybe a low-grade fever, but you don't see it very often. Coughing, hacking, nose is running, they just don't feel good, right? That's our signs and symptoms that we see to start with. If you think vital sign-wise, what's your heart rate do when you have an infection? It goes up, right? So we start to get tachycardic. And when our heart rate goes up, what does our respiration do? It goes up too, right? Because our body's like, hey, we need to. All right. Sorry, I saw you play with your phone. All right, so yeah, right? So heart rate's up, they're breathing faster. What do little kids lose when they're breathing real fast? Water, right? Yeah, right? But they don't want to swallow because their throat hurts. So now we're breathing fast, we're burning off more water, our heart rate's faster, like our body is working really, really hard, but it hurts to swallow, and so I don't want to drink anything, right? Oh, my ears hurt, like my throat hurts. We start thinking about dehydration, okay? So tachypnea, tachycardia, we're gonna see those early on. It's when the kids start to have accessory muscle use, and when they just become super lethargic, and maybe we start to see a high-grade fever. Those are the times when we typically will see them in our world, right? It's not so much the early onset, it's once they're sick, and now we know we need to help them, okay? So, signs and symptoms, questions on that. Kind of hard to see the little guys, but we pretty much hit all of them. Okay. So what are we going to do for these kids, right? So if we're at the point that they've called us, or they've brought this child in, or even an adult, grandpa, I don't know, they bring them in to see us, and we check vital signs, right? So oxygenation, ventilation, these go together. I can ventilate anyone, right? You give me an ambu bag and some oxygen, and I can ventilate anyone. But you can't oxygenate everybody, right? Oxygenation is what's happening at the cellular level. We talked about that mucus plug. I can put the volume in the lungs, but it might not do its job, okay? So we have to worry about both things, because if ventilations are messed up, obviously that affects oxygenation. And so we need to start thinking about what we can do for these things. So I want to hit ventilation first, even though it's at the bottom. So we talked about how ventilation is, I can put the air there, your liters per minute, your volume you're giving them, how fast they're breathing, how slow they're breathing. These are all things that affect ventilation. But when they're really sick, oxygenation might not work so well. So we just got some new ventilators at the fire department, and we've had this class. We talked about ways to increase oxygenation. So what can we do for these kids if their oxygen level is low? What do we do for them? There's two things we can change. One of them's written there on the slide. FiO2, so how much oxygen are we giving them, right? So your FiO2 is your fraction of inspired oxygen, or your percentage of oxygen you're giving this kid. Okay? So if we put them on a non-rebreather at 15 liters per minute, your FiO2 is 100%, right? They're at 100% oxygen. So increasing oxygen is one way we can increase oxygenation, right? Seem easy, right? That's pretty easy. Our other mechanism we're going to use is PEEP, okay? And this is where your CPAP or your BiPAP comes into play, or your high flow nasal cannulas. And so that's why we have some of these toys here that we can talk about, okay? Which after the class, we're going to do a little breakout session and we'll play with some of these machines, okay? For at least for what we can. So recruitment. Now we've talked about FiO2. PEEP, your positive end expiratory pressure. So when you think PEEP, think of like I'm blowing up a balloon, right? And so everybody has a little bit of PEEP naturally. Sorry, this thing's kind of falling apart. Everybody has their own intrinsic PEEP level to help keep things open. But sometimes when we're sick, we need a little bit of help. So if you think of a balloon, or even just a lung really, but when we breathe out, what happens, right? It gets smaller. Okay? Our surface area gets smaller. Well, what PEEP does is PEEP gives us a little bit of pressure to overcome that gradient to help keep the lung expanded. You've increased your surface area, which makes it easier for all that oxygen-rich air that we're putting in to diffuse to those alveoli. Okay? That's what PEEP does. So we don't want to overcome the respiratory system. What we're trying to do is just put enough pressure in there to help keep the lungs inflated to where we get better gas exchange, surface area. Okay? That's what we're doing. Recruitment is keeping that there. Okay? This is very important when your patient is intubated. I will tell you that if you have a patient that has a high level of PEEP and you go to move them to another ventilator, or even if you go to suction them, as soon as you pop that circuit off, you had lost all recruitment that you had gained. All that surface area is immediately gone. So like one of the things we do is like if we transition a patient to a transport ventilator, we wait for the facility ventilator to inhale and you pinch the tube. You keep that recruitment and you immediately put them on the next circuit. Okay. Awesome. All right, so we want to keep recruitment. Once we have it, we want to keep it. So point of care, bedside, if I've got CPAP or BiPAP, probably BiPAP going, we want to keep it. Right? We need to keep that there because it's helping us. It's really helping our patient. Questions on that?
What is a general PEEP that you would do for a child?
3 to 5.
Okay.
Good question. Any other questions? All right, let's keep rolling. All right, so your high flow nasal cannulas, this is kind of a generic slide. It kind of gives us an idea of what we're seeing here. Your settings are usually dictated by, one, your patient's size, what we're going to use, and then also like how sick they are, right? We've got a little bit of range we can play with. The biggest thing I'll tell you that you want to pay attention to when you're using a high flow nasal cannula, we talked about how when they're tachypnic, they're breathing out, they're losing all their fluid. Plus we've got this nasty mucus sitting in their airway, is humidity. You want to make sure you take the time to humidify your oxygen. Even if they're not on high flow, we should be humidifying it, right? Because we're just drying everything out. They need that. They've got that tachypnea going, and just give them that little extra help. Temperature, you do, especially with little kids, we need to control that. They are not able to thermoregulate the way that an average adult would do that. So controlling your temperature is a big deal. Don't want them too hot or too cold, obviously. Like I said, some general guidelines for you guys about like PICU use. I don't know how applicable that is here in this facility, but there you have it. So let's see, some troubleshooting. You know, my temperature probe, are things disconnected, water, kind of self-explanatory. Questions on this thing? All right. You guys have the Airbo system, which we'll play a little bit with that machine, okay? So high flow nasal cannula, and then also the RAM cannula, which we'll hit here in a couple slides. Everything is size dependent because we're looking at how much space we fill in their nostrils, okay? And so you're gonna have like little charts on the side of your package that kind of give you an idea. You're gonna hold up to the patient's mirror and be like, yeah, that looks good. Okay? So a couple different sizes you guys can see there. That does go to your equipment here. So we've,
Danielle, are those kept with RT or do we have, with RT?
Yeah.
Okay, so we'd have to call them to get them.
Yeah.
Perfect, thank you.
and my understanding is like RT is gonna be there to help set those up and get them going anyways,
Yeah.
so good question. All right, so we've talked about PEEP. Let's talk about our ways to deliver PEEP to these kids. I didn't have a PEEP valve with me, but I just wanted to tell you guys that when I have an ambu bag, and you see your little pressure pop-off valve, we can throw a PEEP valve on an ambu bag so we can help create PEEP if we're struggling to get good oxygenation when we're bagging someone. So they do make those. Might be something you want to consider throwing on if you're ever bagging somebody, it just helps. Okay. Pops right on. And then you can turn the little dial and set it to what you want. So we've talked about giving PEEP, okay? Talked about the different ways we might do it. So CPAP, what's the difference between CPAP and BiPAP? Anybody?
CPAP's continuous and BiPAP is when they breathe.
Awesome. Romney, thanks so much for paying attention the other day, man. I appreciate it. All right, so, love it. All right, so yes, BiPAP is basically biphasic, right? So we've got an inspiratory pressure and an expiratory pressure with BiPAP. It's more comfortable for your patient. They're more likely to leave it on, and it just works a little better because they're more comfortable, right? Your CPAP is continuous positive airway pressure. So whatever you set it to, think somewhere between 5 to 10, it's just constantly blowing in their face, and they have to breathe around that pressure. BiPAP works with your patient where it's not so obtrusive, I guess would be a good way to say that. Okay. Your RAM cannula, it's kind of an off-label use of the RAM cannula is that it includes, the RAM cannula is big, and you guys don't have them here, but they include about 80% of the nair, and they're longer. And so with the RAM, one of the side effects is they think we provide PEEP. And I will say we did use them on the helicopter at Airlife, and they did work pretty good. Like, a lot easier than the mask for little kids specifically. So it's continuous, it's there in your face, it does work really well. CPAP became real popular with like CHFers where you're trying to just push fluid back into their circulatory system, but they both do the same thing. Just think BiPAP's a little more comfortable than CPAP in the facility for sure. So, questions on that stuff? So RAM cannula, I just talked about that a little bit. You can see how big that thing is in that little kid's nose. They're kind of the same way as your setup where you got a little chart and you measure the kid's nair, and that's gonna tell you which side to use. And really they work as a high flow nasal cannula that just happens to provide PEEP by mechanism of action. That's how RAM cannula works. All right, so management of these kids, the real reason why we're here. Right off the bat, don't lay them flat. Right? Sit them up. You know, my wife told me this story about they had some folks coming into the ER over in Kerrville, and they're like, oh, our kid just can't breathe, and they're like laying across mom's lap. Like, right? First thing is like, well, let's sit them up. Right? So sit the kid up. If you can't breathe, the last thing you want to do is lay flat. Right? But if they're real small, they can't tell you that. Okay? So positioning is huge. Remember the stuff from like textbooks where they talk about, do I pad under the kid's shoulders if I have to, or do I pad under the occiput? You know, that's going to be based off the kid's head, how big they are, their age. So yeah, position, I didn't really see it on here very, I guess lift head of bed greater than 30 degrees, sit them up, right? Suctioning, this is huge. So we have a couple of the different devices that you guys might see here. In the ambulance, we're going to use like soft suction catheters, but here you guys have a couple different things that you can use for basically sucking their nose, right? So if you're dealing with these little tiny guys or girls, and you know they're breastfed or they're doing bottles, before they eat, you need to suction them, right? Plain as day. Here, I think we have like you should be suctioning at a minimum like every 4 hours. Just think they can't keep up with that snot production. They just can't manage it. And if they're here, they've probably been sick long enough that it's significant. And so we need to be pretty aggressive with suctioning. Humidified oxygen, same thing. That's going to help keep things loose so we can do a better job of clearing their airway, right? Just common sense stuff. Using your normal saline flushes, it's not going to take much with kids, right? You think like, I always think of like this where you get like the old people that's got the trach and you got to like squirt it and then like goobers go everywhere. It's gross, right? That's what I think of, but babies, I don't know. It's easier with babies. Doesn't take as much, not quite as gross, not near as gross. Okay. Physiotherapy, so everybody remember percussion, right? When I went through school in the military, like that was a big deal. We used to walk around all the military hospitals and you do percussion on all these old people. Not really a big deal anymore with kids. Vests, do you guys have the percussion vests?
We have it, but we haven't used it.
All right, so they do make vests, so you don't have to stand there and do that anymore, but, and I don't know if they make them for little babies. I mean, they might, I've never seen them, but percussion, it's a thing. You can try it if you're bored and just don't have anything else to do, but from reading through like stuff on CDC and then WebMD, I couldn't find anything that says that shows that it does anything. It just makes us feel better. Getting them up, getting them walk around if they're able to walk. Again, if the parents are holding the kids, you need to make sure that they have them upright, you know. And your respiratory treatments. So I just want to say that, you know, like your corticosteroids, your respiratory treatments, none of those things have been shown to decrease really anything with RSV, right? So it might increase our numbers temporarily, but it's not going to make any of the process shorter. It's not going to get you through anything quicker. It's really just helping them fight whatever's going on in their body, right? We don't have antivirals. There is I think it's a pre-antigen thing that they're trying, Vaz or something like that. You could look it up, but it's approved by the CDC. It's really only used for preemies and congenital kids, and it's a monthly injection. But it's not like oh, my kid had RSV, why don't you give them the plumivizumab, or however you say it. It's actually a pre-plan. once a month injection. It usually runs for the entirety of the RSV season. 5 months is pretty typical for that treatment, but reading on the CDC website, they have gone longer. The whole COVID thing, like I'm sure everybody has seen in the news, like we're all, RSV is huge right now, and that's simply exposure, right? A couple years ago, everybody stayed locked up, we weren't getting exposed to these bugs, and now fast forward 2 years and everybody's back to school. Oh, so he's back in school, everybody's getting exposed to these germs, and now we're bringing them home. And so these little kids that never were exposed to anything are now getting exposed to these nasty bugs. And so that's why we've seen this increase. The CDC is projecting somewhere between like 58,000 and 100,000 hospitalizations for this season. So that's pretty big.
Can you take a phone call from Opie Moore Clark?
That's really all I've got. The
Do
rest,
you know off the top of your head if that's similar to what it was in 2019?
I don't. Good question. I didn't look that far back.
Just
Good
curious.
question. Good question.
I don't think it was.
No, that's what I was wondering.
Any other questions? That's it. Just how it works in the body and what we're seeing and maybe what we can do about it. Humidified oxygen is going to be our biggest thing, right? Unless they're real sick and we get to the point where we look at